Thanks to the opportunity given to me, and probably I will try to fill the time gap, not the knowledge gap. I'm here to just fill the time gap. So I will take you through two components, the AKI in ICUs in developing world. So for the last 2 days, we have been learning that AKI can cause a lot of problems, not in immediate and later on. So these are the data from India where we see around 1 to 7% of our hospitalized patient gets AKI. And in intensive care unit, 1/3 to 1/2 of your patients may have an AKI. And the other interesting component is the mortality can go haywire between 20 to 60% from different studies. So that's the burden of acute kidney injury in your intensive care medicine. This is a review article which talks about what is the specialty of acute kidney injury in Indian context or in the developing country context. We have a different etiology when a patient comes from a community acquired AKI. That can be a tropical fever. We see dengue related AKI, malaria related AKI, leptospirosis, scrub typhus. These being a pattern when we see the seasonal epidemiological rise in the cases of many of these tropical fevers. Yesterday, we were listening about a pregnancy-related acute kidney injury and obstetrics being a common cause because the early care has been delayed, so that can be a big load. Intoxication, particularly paraquat, or some of those toxins which causes kidney injury may be a big load. Snake envenomation, particularly both your vascular toxic crate and viper can cause your AKI in an early part. Sepsis remain the most common cause, irrespective of all of this. When we looked into our ICU data, the sepsis remain the common cause even in Indian context, probably because the tropical fever also will be included in sepsis. The other organ failure related collateral AKI are also common. Multi-organ failures are relatively more common than what we see in the Western countries and younger age group. The age group relatively younger in Indian context. ICUs in India, when we actually look at different things, one thing makes very prominent, cost being a limiting factor. I'm now working from one of the creamy side of the Hyderabad, the western part in the main IT hub. Believe me, there also 80% of the population who comes, even though they're covered with some or the other insurance, have a limitation. They believe a lakh or 2 lakhs of insurance will be enough for them, just that get exhausted and evaporated within a few hours of the ICU admission. So cost being the biggest limitation factor across, whether you talk about a public sector or a general smaller hospitals or a bigger corporate, all remain the same, that being the bigger burden. So this actually depicts a comparison of disparity between what happening in the developed Western countries to developing or in emerging countries. The pre-renal and ischemic ATN being more common predominantly there in the West, whereas compared to emerging countries, you see interstitial nephritis, glomerulonephritis, probably multi-system issues were more common. I find this little different, but this is what this particular paper says. The septic patients, the severity of illness in emerging countries was relatively lesser than what they have seen in the developing countries. This is again another interesting information from that data, that the maximum AKI stays when they come to the developing countries or in emerging countries, you see the category is more predominantly in the lower down. The AKI 3 staging is more common. That means the presentation is more delayed in Indian context or in developing country context. Renal replacement requirement in these many AKIs are more in Indian context or in developing country context. Criteria to actually initiate a renal replacement therapy, if you see the acidemia based, load based or metabolic based indications are more in developed countries, whereas we see more common with fluid overload or a oliguria being a common cause. This is again the modalities as we expected, the slow, low efficiency dialysis, or now we are saying persistent intermediate dialysis being a common practice in many of our ICUs, whereas the CRRT and other modalities are common in them. This is when it comes to the outcome. The crude hospital mortality was relatively higher in developing and emerging countries. The recovery rates were a little lesser here, and dialysis dependency is also higher here. So if you see the practice, they present late, we probably initiate more of a sled compared to them, And in spite of having a younger age group, we do see a more mortality, delayed dependency on the dialysis, and less recoveries. So this is again the information which I got from the Indian Society of Nephrology AKI registry. I'll just go through what has happened, and most of this data came from more of a public sector hospitals which contributed more of the data. These are the demographic variables. As I said, 43 is a mean age in that particular, which looks younger age group. And these are all demographic variables. Socioeconomic issues in Indian patient when they come to the hospital, either a public sector or a private sector, remain to be a bigger challenge. They are always compromised. They are always from the lower socioeconomic background. And this again, the initial presentation, if you look at the seat of this AKI registry from the Indian Journal of Nephrology, you will see the creatinine at presentation was 9 as a mean. So that means there is a delayed presentation in many of the situations. This is again the signs and symptoms presentation to the hospital of an AKI patient. If you see febrile illness takes a bigger load, probably that adds to your tropical illnesses here. The medical conditions take more load of AKI than the surgical and obstetrics, even though we believe obstetrics has a bigger a component in India, and these are the etiological factors which has been contributing to that AKI. As I told, the ischemic ATN, other than that you have malaria, dengue, lepto, pancreatitis, snake bite contributing to some of those AKIs in India. And this is the hemodialysis requirement across probably first 2-3 weeks of time. The second day was the highest. As the days progressed, it came down. Again, this is the staging of the AKI at the admission. You see the stage 3 being the common numbers, the common presentation. And this is according to the rifle criteria, where the failure was the more common presentation. And these are the discharge creatinines after 1 month and 3 months follow-up in that group. And these are the recovery stages. The initial admission time, there were around only 349 recoveries out of the total probably 2,500 patients. Later in a month, you see the recovery progressed from 1,000 to around 1,800 in later part of the 3 months. So with this, when I came across the different ADQI guidelines or consensus group statements, I see what is the difference between a already Western developed nations to what we are emerging developing nations. The availability and cost is a bigger challenge. The guidelines apart, but do you have the availability of all these resources at you? Is the patient able to bear the cost is one of the biggest challenge. Probably we have a more severity of the cases of AKI which present to us. We have a different etiological spectrum compared to what we see in the Western countries. I think in the last couple of days, what I learned is we have been going through this different studies coming up in the last maybe 5-7 years, debating, challenging the earlier medical school concept which we learned about initiating a renal replacement therapy, the timing of a renal replacement therapy, the modality of a renal replacement therapy has gone to a toss with different debates and variations in the study outcomes. But what I found is the absolute indication remained to be the standard from our medical school days to till today. Those are all standards. Severe metabolic acidosis, hyperkalemia, a pulmonary edema, uremic related, a severe encephalopathy or something remained to be a standard of here. But the question remained is, if you do not have a absolute emergent indication of dialysis, if do you still need a dialysis? For that, I think the couple of days we have been discussing and focusing about the decreasing capacity of your renal function to actually eliminate the increasing demand of your metabolites, solutes, volume, load, or a catabolic state. That's what has been discussed across the last 2 days. So your kidney capacity and demand, if you believe they are been balanced and you still believe the kidney has a capacity to handle it and you are trajectorying that the kidney will have a recovery, probably yes, you may give a chance. Otherwise, probably you will need to tilt. That's been the lesson of the last couple of days which I can see. When we talk about a capacity of a renal function, is it normal, low? What is that? It cannot be high. We see a very augmented renal clearance. That's not a context today, but normal or low. When the demand is high, whether you are in a high catabolic state, you are in a severe sepsis, you are in a severe acute pancreatitis, if you are in a malnourished state. So it depends on what is the demand of your metabolic demand of your body at that point of time, and is your renal functions are capable enough to take care of those demands has been discussed. So how do we actually look at the metabolic demands and fluids? There are scoring systems, there is a volume overload assessments, and chronic comorbidities will guide. So this is what I think as an intensivist in the last couple of days what I learned, and probably the reason why we have that dilemma in our mind is in the recent times, in the last 3 to 4 years, we have seen a couple of studies which has been well validated at that point of time, even though there were challenges saying they have been excluded of organ dysfunction. Those who have a chronic organ dysfunction has been sided in those studies. They had a 36 to 50% of the patients who are assigned for RRT, late RRT, did not require renal replacement therapy. That means 50% of those patients were never required a RRT. So this probably gave us a little insight key, highlighting the effort we should make to identify those patients who have a high probability of a renal recovery. Yesterday we had a 2-3 case discussions where we have seen a patient who was initially having a AKI, after all supportive care has worsened. And both those cases we went back and thought whether we would have been initiated the RRT much earlier. But just imagine, it doesn't happen every time. I initiate a standard antimicrobial therapy, give a volume resuscitation, I augment my pressures, many of the times the patient improve. It's not just creatinine or organ functions improve, lactates get clear, my hemoperfusion or a perfusion gets better. So probably in those situations I may have a different way of thinking in them. So this is probably opening up a side that whether we need to wait for those where there is a probably chances of early renal recovery. The bottom line is renal replacement therapy should be considered irrespective of whether there is an absolute indication or not, when your capacity of kidney cannot meet the demand being placed onto it. And you also have to imaginarily have a trajectory, clinically trajectory, whether my patient has a chances to recover or not. And that will be again a subjective phenomenon which will vary from a person to person. So the other bigger challenge in developing countries, as I said, is just not resource limitation. Just not a resource limitation, but also the ethical dilemma of appropriateness of initiating a RRT when it comes to a young, healthy individual who is hemodynamically unstable, has a cerebral edema, he says, I can't afford. So these are all ethical challenges which we face day in and out. It's not uncommon to have these situations. And you know, particularly when it comes to a continuous renal replacement therapy, the cost goes beyond the affordability of many of our population. So again, the second question is what form of RRT? This has been again a debate. We said except probably 2 situations in Indian context also, if a patient is hemodynamically unstable, requiring very stiff doses of vasopressors, minimal dose of vasopressors, probably will still go ahead with a sled if available. But in a stiff doses of vasopressor, hemodynamically unstable, not allowing the solute and the fluid exchanges, then probably a CRRT. And the other indication is raised cerebral edema or a ICP patients, either a hepatic encephalopathy or a trauma or all other reasons, probably we incline towards a indication of a CRRT. Other than that, in the last 10 randomized control trial, including the meta-analysis and Cochrane collaboration, we could not actually demonstrate the benefit of renal CRRT, the continuous, which we say smooth, gentle form, has any upper advantages over the intermediate or low efficiency dialysis. Yes, probably this is an add-on to a context which I am dealing with. When I have an ethical dilemma, I will still continue to use a persistent intermediate low efficiency dialysis to continue in many of the situations where I can come back. So this is probably a summary of all the different situations where I can opt which will be the modality of the dialysis, which again is for the developing countries from intermediate to persistent intermediate dialysis to CRRT, depending on whether I have a life-threatening complication with hemodynamic stability or hemodynamic instability or a brain injury, or I have a high catabolic state. So we have guidelines from Indian Society of Critical Care Medicine from the intensive care perspective, which again echoes the same way, indication remain the same what we discussed. and the timing remained the same, and the modalities remained the same. They said all these, the same things were been echoed by the guidelines. The second quick part of mine is, I am being interested in this acute kidney injury. We thought of one chronic problem which we could not solve. Many of us come across this acute kidney injury in our ICUs, and we decide to dose our patients. And the kidney function dynamically, continuously changes from hour to hour depending on the renal function. So we use some of those old modalities which has been either a CG modality or MDR modality to calculate the eGFR and dose our drugs accordingly, which has never been validated in acute kidney. They are all been validated for a CKD patients. And we try to extrapolate them and try to use them in a acute kidney injury situation. So we try to look for a kinetic GFR, which actually takes care of volume of distribution. As we all know, the initial part of an acute kidney injury with a volume logging, you may have an increased volume of distribution, which may need a higher doses of initial, at least antimicrobials in that form, later on adjusting according to the dynamics of your kidney function. So we wanted to look at the kinetic GFR in them and validating it and comparing it with MDRD and CKD EPI equations. And we also wanted to see the mortality associated with the kinetic GFR progression, and also comparing the doses of different antimicrobials which we are using in ICU. We have not intervened. We just saw what is happening if I dose them with CG method, what is happening if I dose with MDR method, if I dose with a kinetic GFR method. We have not intervened. We have done a pilot analysis to see, do we find a gross difference in antimicrobial dosing. For example, we have taken a beta-lactams, carbapenems as being the commonest drug which we use day in and out. We all do our own ways, saying gram BD, or sometimes say 500 gram TID, or sometimes we say 500 gram OD after dialysis in CKD patients. But in an acute AKI, this dosing goes haywire. It varies from individual to individual with different ways. So we try to look at those dosings also. The standard inclusion criteria were taken, exclusion criteria for all the CKD patients, including those who has a renal parenchymal changes or those who had actually shrunken kidneys. Ultrasound was been taken help of, and those who has received a renal replacement therapy were taken out. Obviously, renal transplant cases also has not been included. We took all the scoring systems and all the formulas every way, and this is a formula which we used, and this is how we actually collected the data from the baseline of creatinine day 1, day 2, day 3, and kinetic GFR every day, and CKD EPI every day, and MDRD for first 3 days. And we are also looking at need of RRT and renal recovery. We actually looked for around 60 cases, and we wanted to just present this data to see. These are the initial preliminary pilot analysis which we actually did on comparing them and comparing the meropenem doses, and we didn't find any significant difference. This is a very small sample of 40 to 60 cases, so we are still waiting for a 12 months of maybe around, if we go in the same rate, around maybe 600 cases in this 12 months from 4 of our units, and that may give us a validated information whether we can use another tool which may be more valid and validated in a acute kidney injury settings. Thank you.